So this patient's coming in for removal of a mobile lesion just on sort of the distal aspect of her forehead. This is as the characteristics of a pilar cyst. I'm working with Dr. Lacroce today, so he might be answering a couple of questions for us. Do you remember why pilar cysts form in the first place? It's kind of a bit of a guess what I'm thinking, because the reality is they're not entirely sure. So epidermoid cysts, which you'll find outside of a hair follicle, they think those are caused by trauma, which drives the epidermis into the dermis.
Okay.
But these ones are not sure. At the base of every hair follicle is a mucus secreting gland.
Yeah.
There's this concept of what we call retrograde secretion, where it's injecting it downward, and then it forms a capsule, and that's how it forms. But that's never really been proven out, to be honest. So she's already had some anesthetic. We've injected underneath the cyst. And Anne, again, you don't feel that at all?
No.
So we're going to do incision now. We could clip her hair down. We're not going to cut any of the hair out, but we'll clean it up afterwards when we're all done. So we're just going to do a superficial incision and then sort of widen it out and see if we can find a cyst capsule. So this is number 15 blade. And as I've said before, I think the key with these is as long as you just progress slowly. So I like to use blunt dissection with these. I do warn residents that scalps do bleed a lot. So these tools are called curved Criley's. They're sort of like the little brother of a Kelly's clamp. So what we're looking for here is the cyst. Mike, have you seen a lot of these?
I've seen a few of these.
Okay, so the biggest key with these is just getting familiar with the tissue that you're looking for.
Mm-hmm.
So if you can see here even already, can you appreciate that sort of pearlescent tissue that's there?
Mm-hmm.
So that, I don't know if that transmits onto the actual video, but you can, that's what I want to be looking for, because that's the cyst itself.
Right.
It's just sitting right there. And this is why, again, you go slowly. So this was barely an incision, and it's right there beneath it. Now again, if this ruptures, if you rupture the cyst wall, it's not a big issue from that perspective, but in general, I like to try and see if we can keep it together as best we can, to see if we can get it out clean. And you should be able to appreciate that that's a good cyst wall that's sitting there. So what I like to do with these is I'll just widen the incision just a touch. So in this particular case, it's the posterior aspect that I want to widen. So what I'll do is I'll just put the Criley's in. And I do this just because it protects the cyst a little bit. And then I'll just add a little incision here. Just the back aspect of it. See how, and again, this is the nice thing why residents, if you're training with this stuff, it's nice to learn on the pilar cyst, because the scalp being behind them, they're easier to take out. So now what I'll do, Mike, with these is I'm going to put the Criley's in, I'm going to open up a bit, and I'll curve it like this, because it'll break down adhesions behind it.
Okay.
Now sometimes the caps will rupture a bit with it, but a lot of times it doesn't. And Anna, you're okay there?
Yeah, it's just a little bit of pain. That's okay.
Is it pain or pressure?
It's pain.
I'll give you some.
That's okay.
No, but if it's something we can add to. So this is not an infected field, so she's uncomfortable with it for sure. Then we just add a little bit of extra freezing in. Give you a poke here. Doesn't hurt too much there?
No.
So I'm just adding a little bit on each side. And we had talked this beforehand. So with these ones, so you can see how that just wants to push it out because I'm putting back pressure on it. So if you're injecting into the epidermis of dermis, you don't have to draw back. You start to get deeper, and you want to make sure you draw back to make sure you're not in the vessel. So you're going to rotate through again. Just going to do the same thing again. it. Just like that. You can see through here, this should be all keratin sebum material. That's through there. And you can see that, it's just coming out. And that's all that is. But now we know, so now we're completely comfortable with the fact that this is 100% clear. And now we're just adding a couple of stitches. And there really isn't a reason to trim the hair. It sometimes may make my job a little bit harder. And there will be a couple of cases where I'll talk to patients ahead of time. It just so happens that Anna has a wedding in a couple weeks, so we certainly don't want to be causing a bigger problem than we have to. So the nice thing is the Proline, this is why it's blue, because a lot of people's hair color will come into it. So you won't need any dermal sutures here, because this is just superficial. And again, we've taken mass out, so this should close over nicely, and there shouldn't be any risk of losing the incision or having a dehiss on us. So pulling this through again, if you're just learning, we do 3 loops. Then we grab the tail, and you want to pull it till it's just laying flat. Then you do 1 loop, grab it. I do that 2 more times. I'll make those a little bit shorter on purpose just because, again, she has that wedding coming up. So I was going to have 1 more. So again, when you're putting your needle in, as long as you're perpendicular to the skin, at 90 degrees, you'll just find that it punctures easier. If your angle's off, you'll find you fight that a little bit. So 3 loops, grab the tail end. Make sure that lays completely flat. That. Anna, you're okay?
Yeah, I'm fine. Thank you.
That's it, and that's sealed nicely. We shouldn't have any trouble with that. So she'll come back in about 7 days to get those out. That's it.